So good afternoon, ladies and gentlemen. Welcome to this afternoon session. And I have to apologize, Fermin Garcia, who is already in the other hospital in Homolka. It's not close from here, so he went there already. And I will handle this session because it's easy. All 4 lectures are pre-recorded, so they will go in one after another. And then we have time for discussion. And after discussion, you have break, and then we have live cases. So we don't want to waste time, that you can enjoy live cases. And let's start with presentations.
Dear colleagues, dear Joseph, thank you so much for the invitation to present on the role of CT to identify VT substrate. I'm Pierre, and these are my disclosures. So when it comes to cardiac imaging, and particularly for VT substrate, we all have in mind the role of MRI, and we probably have underestimated the role of CT scan, which in my opinion is in fact superior to MRI for post-MI VT, and I'm going to try to explain why in the next few minutes. So there are plenty of things you can do with a CT scan, which is largely available with no difficulties in patients carrying an ICD versus what is happening in MRI. So if you get injected with iodine CT scan and look at the arterial phase, you get access to a very accurate, with a very detailed spatial resolution, wall thinning assessment of the scar. You get access to the fat infiltration, which has some implications, and to the calcifications. And these are the type of images you can find with late iodine enhancement, which is pretty similar, even if it's a little noisier than what you get with MRI using late GAD enhancement. So the substrate assessment is multiparametric with CT scan, and you can see in this patient that the late iodine is giving you a pretty nice description of this inferior myocardial infarction, and very similar to what the late GAD enhancement with MRI is showing. So you can also use some FDG uptake. This is a sarcoidosis patient here, which was helped guiding some ablation case by Jeff Winterfield in the US. So as a summary, you get access to a color-coded wall thickness, which I find very helpful to guide VT ablation. I will show you how in the next few minutes. The scale, the color-coded scale, is always the same. So the dark red is less than 1 millimeter, and then all the way to the bright yellow, that is 5 millimeters, and everything in gray is over 5 millimeters. Again, fat infiltration has some interest. I will show you why. Late iodine we mentioned, and again, it's pretty close to late GAD enhancement with MRI. Now, to get access to this late iodine CT scan images, you have to have a recent version of a modern CT scan. But apart from that, CT scan is very versatile, and there is no thresholding issue when it comes to the intensity of pixels. All the CT scans are calibrated the same way all over the world with water. And that's very different from MRI, where it's the radiologist who will decide which threshold he uses to define scar and gray zone. Now, we spend a lot of time validating methods for imaging with the music in heart effort. Music is the academic version of what we developed. In heart is the software company that is making it viable to everyone interested in the world. We also did quite some work validating the images and the definition of scar, of late potentials, lava, etc. In those papers here, And then image-guided ablation was also used. It could be phrased as image-aided when you do not import and merge the 3D reconstructed model of your patient into your navigation system, or guided when you do so, which is of course the best way to proceed. Now, I mentioned that scar was interesting. If you look at this series that Hassan Chiniti reported from our group, you can appreciate in blue is the cumulative survival in patients with no fat deposition on CT scan, and in green with fat deposition, meaning fat infiltration in the scar. And you can appreciate that it's completely different and that fat carries a poor prognosis in itself. It also works for individually for all-cause mortality and for VT recurrences that are way more frequent in case of fat infiltration in the scar. Now, arterial-only CT scan works very, very nicely in ischemic cardiomyopathy. It's not so good in non-ischemic because there is not always a wall thinning associated with that kind of condition. It works not so well either in IRVC or similar RV conditions, except that you have the fat infiltration in IRVC. That is quite interesting indeed. But then if you have a modern CT scan where you get access to both the arterial and the late enhanced phase, you see that it becomes pretty similar whether you use CT or MR. And it's only for the RV that late enhanced MR high resolution is particularly helpful. Now, this is not completely true because high resolution sequences associated with late enhanced MR are in fact useful in many conditions. But again, the limitations with MR are pretty important and will prevent to get good images in patients with ICD. You can image them, but the quality is suboptimal. And cardiac MR high resolution is very rarely available in centers doing VT ablation. So this CT wall thickness is really interesting. It benefits plenty of the very high spatial resolution you get access to using CT scan, and it defines the heterogeneity of the scar. It helps visualizing these CT channels that are these areas of relatively preserved wall thickness. We're talking about 2 to 4 millimeters. And these areas are typically bordered by areas that are acting as barriers during VT, where the wall thickness is 1 millimeter or 2 millimeters, and where the likelihood for surviving bundles of myocardium is much less. And then you can run some interesting studies and start looking at statistics on the shape of these CT channels. And you see that most often they're straight. Their thickness at the center is 3.5 millimeters versus less than 2 millimeters at lateral boundaries. And you can start running artificial intelligence as well, which is probably very promising with this topic. And this is showing you one of these validations where we've got both the digital twin of the patient with color-coded wall thickness and the VT that was induced, confirming that the VT isthmus matches perfectly with the CT channel. If you look at this figure, it's interesting to notice that we were able to identify that the CT channel was hosting a VT isthmus in only 50% of cases, and this is completely normal. We all know that not all patients are inducible, and that not all VTs are inducible. So it's likely, though, that what matters most is the sensitivity. And if you look at the performance of CT scan wall thickness analysis, it's very rarely that you find a VT isthmus that is not in the CT channels identified. So you can also deal with very complex scars, and this is the case here, very heterogeneous, multiple CT channels. Again, we've got that VT isthmus that matched with this CT channel here, but we would provide a treatment that takes care of all channels, CT channels, and thereby probably have a chance to get a better outcome. Now, it's also interesting to see that there are some characteristics with the length and width of these channels when they are hosting some diastolic activity during VT, whether not hosting them. Again, I think that artificial intelligence will really help here. You can also appreciate that even if you perform CT-aided ablation, meaning that you're still doing some degree of mapping, you can appreciate that the total mapping time is significantly shortened and the procedure time is significantly shortened. So from a procedural standpoint, it's very simple. The way we use it now in Bordeaux, and some centers are using it differently, we have a very simple workflow where first step is to register the 3D digital twin of the patient in the CARTO or arrhythmia or end-site coordinates. And for that purpose, we would fast map the aorta, as you see here, and then align it with the CT aorta reconstruction. Second, we straight go to ablation, targeting the CT channels. And third, we assess inducibility. So it's a very fast and easy procedure. You see here in green the CT channels that we have identified from the CT scan, and you can start planning your ablation procedure. You see that the ablation dots are placed in the most vulnerable part of the CT channel, where the wall thickness is the least important. And again, this is how it looks like in your CARTO station. Procedure duration in this case, less than an hour and a half. And this is pretty consistent over the last 40 patients we did in Bordeaux, where we've got 75% success rate at 1 year with a single procedure, which is quite good. And interestingly, the procedure duration is very consistently less than 2 hours, with a standard deviation that is very minimal. We're about to start a randomized controlled trial where we would compare this approach to a more conventional one in 15 European centers. Now, what is going to happen in the future? Well, first thing is that we will have access to photon counting CT scanners. Maybe more time in discussion later, but the spatial resolution is simply outstanding. 100 micron cubic voxels. This blue thing here on the right is the voxel by the CT scan. In green is conventional CT scan, and in pink is MRI. You can tell the difference easily. Now, what I see in the future is that we're going to use PFA with some big footprint ablation catheters. PFA is going to provide very homogeneous and durable lesions, and combined with image guided, it will make the ablation of VT in fact simpler than PVI for paroxysmal AF, in my opinion. This is showing you the wall thickness of different combination of the lattice by Affera with 1 repetition. 4 repetitions, you see that you're close to 9 millimeters depth, and lattice RF is providing you a very significant depth that is going to be super useful for patients with these intramural or epicardial scars, possibly rendering epicardial approach obsolete. As a comparison, this is STSF radio frequency ablation, and you see that PF can in fact compare favorably to what we have at the present time. And I want to thank Ila Danter for sharing those with me. Now, you can appreciate that the lesion shape is impacted by the catheter you use. This is the Farflex by Farpulse. This is a focal catheter. And this is the Lattice by Affera, all of them being used with PF in this example. So again, in the future, we will combine both this image-guided ablation approach, where we do not map and straight ablate the CT channels, and these big footprint catheters will fit perfectly for a one-site ablation strategy per CT channel. And so you repeat that for here 1 channel, 2, and 3, and you're done. So it's going to be super fast and effective. I thank you so much for your attention, and I'll be happy to take your questions. Thank you.
Thank you very much for the kind invitation, Josef, to talk about high-density mapping to identify VT substrate, and congratulations to the whole Prague Rhythm 2022 organizing committee. It's a great honor to be speaking and be a participant of this. My charge is to really talk about what we've learned using ultra-high density mapping tools about VT. And here you can see that in 2008, we started trying to do validation of a multi-electrode catheter with 20 poles here with EnSite system compared to point-by-point Cardo, which was clearly the gold standard at the time. This was published in 2010 when I was doing my super fellowship with Shiv Kumar at UCLA. And it gave us the confidence that in the same amount of time, we could obtain over 3 times the density, identify twice as many late potentials, and also have equal accuracy compared to gross pathology and histopathology. So we've certainly moved away from point by point as a field, and those training currently certainly use ultra high density mapping with either a pentarray, an Orion, a grid catheter, and they take that for granted that it used to be point by point, and the accuracy was not very clear. The holy grail of VT ablation is being able to find this area during sinus rhythm. And the real question is, what does the isthmus look like during sinus rhythm? And that really forces an investigator to map the VT in its entirety with good delineation, and then overlay the circuit on a very high density sinus rhythm map. And this is what we began doing now about 8 years ago. And isochronal late activation mapping is nothing more than a sinus rhythm propagation map with activation that is annotated at the offset of the signal or last deflection. And this allows us to capture all the late information. So it's really the completion of local depolarization. Our question was really, can we ablate areas that are slow conduction, deceleration zones, and do targeted ablation that might obviate the need for homogenization? And here in this example of a 56-year-old gentleman with 2-vessel coronary disease, moderately low EF, you see this larger area of scar, and if you're going to do homogenization, there's a lot of areas that probably need to be ablated. This VT is also a right bundle with 3 greater than 2, indicative of something coming from the mid to basal lateral wall. When we change this to an isochronal map and you actually propagate it, you can see there's 2 areas of wavefront discontinuity and deceleration zone. Here, specifically, you have green, light blue, and dark blue, which is 3 colors within 1 centimeter, which is how we define a deceleration zone. And then you also have an area that is a potential area of deceleration here. The electrograms are perhaps the most important thing of any electroanatomic map, where you see the normal voltage and amplitude and width suddenly get low voltage and suddenly wide. And here you can see there's these far field split potentials that occur right between 910 and 1011, right here where the catheters lie. So this is what we call wavefront discontinuity, with evidence of some slowing of conduction because the electrogram suddenly gets wide. This was shown by Andy Witt and Chachow and colleagues about 15 years ago with preclinical models of looking to see where there's sudden electrogram width changes. If we focus on the deceleration zone rather than the area of latest activation, and we induce VT, you see that the VT circuit does not require activation of the latest area in sinus rhythm up at the annulus, but yet the nidus for the VT circuit is all within the zone of deceleration. And here you can see in exquisite detail, we have all of the diastolic activation, every millisecond recorded with a linear catheter measuring this reentrant circuit. When we are able to map VT in this level of detail, we start finding a couple things. One, the circuit is quite narrow in its dimensions. And number two, it doesn't require much ablation. And here in 5 seconds, the first RF application rendered this completely non-inducible. And as a matter of fact, 57% of the time, we can terminate VT in the first RF application, and 76% of the time, it can terminate within 2. That tells us that the VT circuit is actually quite small in the sense that you can eliminate this with very few lesions. Very large or wide broad isthmuses need more ablation to be able to eradicate them. So in this series, prospectively, what we did in Chicago, now 4 years ago, was 60 versus 60 ischemics and non-ischemics, where we did a very targeted ablation strategy. Here we do an isochronal late activation map. We do confirm local discontinuous activation with offset annotation. We look to see that the electrograms suddenly go from narrow to wide. If we have a single deceleration zone, we focus on that area. If we have multiple, we prioritize one by looking to see which one is more maximally crowded, which one has later activation. Those are the ones that we preference. And then we obviously can always use pace mapping, which is standard. If you have 2 and you pace map from both, and one matches the VT, that would be obvious which one might be more relevant. Then we induce with as many electrodes around the deceleration zone as possible. We call that strategic multi-electrode positioning, and I'll show one example of that. Then we are able to quickly, even if it's unstable, be able to map a little bit of VT, and then we do targeted ablation. If it's not inducible, we're done. If it's still inducible for the same VT, we reinterrogate that deceleration zone. If there's another VT, then we reassess the other deceleration zone for functional significance. These deceleration zones are nothing more than pebbles in a stream. They are fixed barriers that create a discontinuity of the wavefront, and we found that over 50% of them are actually created by a localized line of conduction block, evidenced by split signals. It is interesting that we used to just look at late potentials and say they're late, but we don't think about a split signal, which in EP is indicative of a line of block, as indicating that there's likely a small line of block within the scar. If there is a line of block, that would be a great candidate to be an isthmus boundary. And if that line of block is present during sinus rhythm or a paced rhythm, then by definition, as Andy Witt has defined, this would be a fixed barrier rather than functional, which is only present during tachycardia and not present during a baseline rhythm. This would be an example of strategic multi-electrode positioning in which you have a VT that's 250 beats per minute and it's not sustained. I believe that most people would think that this is not the ideal case to map during VT, and it's also non-sustained. This is what most people would call an unmappable VT. Well, if you have information from the ILAM during sinus rhythm and you see that there is an area of significant wavefront discontinuity and conduction slowing, then you can position the catheter in this area and anticipate that this is an area you want to interrogate during VT. There are many labs in which you induce VT, you hope for the best, and you start moving around. This is probably not the best strategy. So with this positioning, we're able to see that this very rapid VT that's untolerated, non-sustained, was able to be mapped the entire circuit with the diastolic corridor. Not only do you see diastole that is moving through these electrodes and back up with this very rapid VT, you're able to appreciate something quite beautiful in the sense that you can map why and where non-sustained VT fails to propagate. And here you can see you have block within the isthmus between these two electrodes. So again, quite beautiful when you can anticipate based on the isocronal activation map. And this is why we're able to map any VT circuit, even with one beat. This is one beat contact mapping. Our outcomes were quite good for VT. SCAR VT is typically 50 or 60% success. This was 80 for ischemic, 63% for non-ischemics at 1 year. And mortality rates were consistent with previously published, pretty low, 4% in non-ischemics and 23% in ischemic cardiomyopathy. What's most important about this series was that we only ablate less than 1/5 of the entire scar. So this is not complete homogenization, but may be able to achieve outcomes that are similar to that with only 29 minutes of total radiofrequency ablation delivered. So we've certainly moved from HD mapping with 75 points in 1998 when CARD was first validated to several thousands of points when we get to NAVIX and that validation in the 2008. And then Elad Enter and Fred Sasher in the Bordeaux group did some beautiful work with arrhythmia, with Paulo Della Bella as well. And this is important because this here shows that we have totally moved the whole entire mapping technology strategy to be able to define and characterize substrates. But does it really matter? Well, this has evolved just the same way as televisions do. And once you get to high resolution, it's very hard to go back to low resolution TV. In fact, it almost feels uncomfortable to see things in low resolution. But Jacques de Backer, now 33 years ago, said he believed it is impossible to follow all the activation in all parts of the circuit because of the rambling course of the tracks. And also, it would require a lot of electrodes. And this would also require very small interelectrode distances. So one of the finest minds predicted that it would be impossible to be able to map the entire VT circuit. Well, 33 years later, the impossible is quite possible. And it happens without limited frequency quite commonly. And here you can see with this example, with a linear catheter, we have every millisecond of diastole in the isthmus that's mapped from the early diastole to late presystolic activation. Whenever we do map VT, we try to propose an isochronal standardization where the window starts at the Qrs onset. Therefore, you always have the same color scheme in which purple meets white is where your Qrs breakout is. You can then trace back from purple to white and go dark blue, light blue. Yellow meets green is at that 50% point, which is the mid-isthmus that Stevenson defines as 50%. So then 25 to 75 is somewhere in the isthmus, and everything that's proximal is entrance and everything that's distal is exit. This then allows you to put this onto a color map and see the beautiful activation of it. But it doesn't really require HD mapping. It requires HD catheters and electrogram analysis. Now, how large is the circuit? Well, here is characterization of a circuit without any electron-atomic mapping, without any high density flare here. And what you can see is that with these 4 bipoles that are 2 millimeters apart, we record a large far-field component in systole, and then you see that there are near-field components in diastole that span all the way to the next. This is quite beautiful, but what's relevant about this and why I'm showing it is that this electrogram, this recording this bipole, actually captures over 80% of all of diastole. That's quite impressive. How large is this? Well, it's a 1 millimeter ring, and it's a 2 millimeter spacing. So this is really a 4 millimeter electrode area. And this 4 millimeter is quite small, that you can capture all of diastole in a 4 millimeter area with spatially distinct areas. Well, if you say I want the whole circuit and take all 3, that's about 1.6 centimeters. So this is actually quite small in terms of dimension. And we found that 52% of circuits have a minimal isthmus dimension of less than 1.5 centimeters. That is relevant because this is allowing more detailed characterization of the actual size, the width, and the dimensions of the critical isthmus. Well, what is the definition of localized reentry or micro reentry? Micro reentry is probably cellular, but localized reentry, here's a proposal. we propose that over 50% of the tachycardial cycle length of diastole is recorded within a 1.5 centimeter path. Why is that? Well, de Backer could not record the whole circuit, and he was using terminals and distances of 1.4. So maybe they just weren't able to record in between these areas. This was published in JACC in 1990. The grid catheter is conveniently 1.3 by 1.3 centimeters, and 3 electrodes is about 1.6. So that's interesting because you're using known distances to be able to use it as a ruler in the field. This is true field scaling. And then the other thing is that if you can eliminate this with one ablation lesion and eradicate it, well, Andre Davila taught us that a really good lesion can be about 1.5 centimeters wide. So this is actually the size of a US dime, and it's actually quite small compared to a US dime because US dime is 1.55, 1.6. So here's a grid catheter sitting on top of a dime, and you start realizing where all the action is actually quite limited. And this would be a proposal for a localized reentry. And here's exactly showing that the long axis dimension can be 1.6 centimeters in scar and normal tissue with irrigated RF. Here would be an example of localized reentry, 1.5 centimeters by 8 millimeters in the peri-aortic area. This is not uncommon. If you had low density mapping, you believe this might just be focal. You might miss these outer loops and the entrance here. Again, showing that the electrogram that creates this beautiful map is really all here. Note the first bipole is an early systole. Note the third bipole is presystolic. One single bipole is spanning entirety of diastole. Note also that the noise level is quite low. This was successfully ablated in 16 seconds and terminated with 1 RF lesion. The longer the electrogram, the quicker the time to termination. And that's because it's very, very hyper-localized. What do we do when we don't see parts of the circuit? Well, understanding with high-density mapping that if you've moved everything around and you're missing activation, that could indicate you have activation intramurally. Here you see an activation gap with a figure of 8 conduction. You're missing several colors that are yellow, light green, and light blue. You go to the epicardium and you see a little bit of light blue surface, the same at figure of 8 pattern, but what you're doing is you're missing components of the circuit. This activation gap right here is the problem where we're missing the early part of diastole. This is the duodecic catheter that has equal contact force in one single position that is missing these components. There is nothing even far field spanning between these populations in red and then the population in blue that's emerging. When you take all the colors that might be missing on the epicardium and the endocardium and you plot the ones that are present, then you can then make a logical inference of what's mid-myocardial. And this would be a very good example of dissecting the circuit with high density and able to ascertain that this is likely a mid-myocardial circuit because we're missing the isthmus activation and the isthmus components during VT. Another important insight is that we always talk about VT as an epicardial VT or an endocardial VT. Reminder that we only localize the exit region. The exit region is the portion that is activated during Qrs onset. Purple and white is where there's exit. And in this example, you have activation during Qrs onset on the endocardium as well as the epicardium. This is a perfect example of how VT lives in 3 dimensions. And here you have more of the VT circuit on the epicardium in an ischemic cardiomyopathy patient. And here you have less of the circuit, but you still have critical isthmus. You're missing a component here with an activation gap, but you've got exit on both surfaces. We found that 67% of circuits have transmural activation during Qrs onset based on high density mapping. This is relevant because the binary system of epi versus endo might not be biologically accurate. The majority of circuits propagate in both surfaces and they break out broadly on both epi and endo. We found again that the vast majority of these circuits are composed and consist of 3D circuitry where you have partial circuitry on the endo, partial on the epi. And here again, you can see that 73% of ischemic cardiomyopathy, if you map the endocardium and the epicardium, you will find components of the circuit on both surfaces. In non-ischemic cardiomyopathy, it tends to be more compartmentalized, but three-dimensional circuitry is the most predominant. Lastly, are VT circuits larger that are slow, and are the faster ones small? Here is a quick analysis of conduction velocities between fast and slow VTs. We noted that the conduction velocity at the entrance, there was no difference between fast and slow VTs. There was no difference in isthmus conduction velocities in fast and slow VTs. There was no difference in the exit regions that were statistically significant, with the exception of ischemic cardiomyopathy, with slight difference with faster conduction velocity at the exit. The most predominant difference was really at the outer loop. And the outer loops were much more rapid in the fast VTs than the slow VTs. And this is really what the main difference is that differentiates the rate of a VT circuit. So what we've found here is that you can have a 2x2 where you have large circuits and small circuits, fast and slow, and you can get every combination. We cannot make inferences about the rate of a VT and the circuit size and vice versa. We've also tried to question the status quo, and with a dual loop tachycardia, looking at whether the double loop reentry is indeed the mechanism or if it's actually just the appearance or the pattern. Here you can see we did entrainment at the lower outer loop here, and this is an in-circuit response, whereas if we entrain in the upper outer loop, we get an out-of-circuit response, which is quite beautiful. A systematic interrogation of this, whenever we interrogated both loops, we can never prove by entrainment that both loops were actually part of the active mechanism, suggesting that the vast majority of VTs are single loop in mechanism with a double loop appearance, one of them being passive. Here, we found that the active loops are typically the smaller radius of curvature. So, ladies and gentlemen, through HD mapping, we understand the nature of VT much better. The sinus rhythm characteristics with the deceleration zones are perfect niduses for entry. We now appreciate that VT, although it propagates in 3 dimensions, is actually quite small and often very localized, less than 1.5 centimeters in dimension. The circuit size did not appear to be correlated with VT rate, and double loop figure of 8 patterns are merely patterns and not mechanisms. And when we start entraining these, we start realizing that maybe half of the butterfly is only the active portion. Thank you very much for the kind invitation.
Good afternoon. My name is Fermin Garcia from the University of Pennsylvania. Thank you, the organizers, for inviting me to participate in Prague Rhythm 2022. My role is to present how to identify and ablate intramural substrates. The first question in electrophysiology, it's how to identify the enemy and what is our clinical problem. I want to start with the simple things, which is the electrocardiogram. This is 2 different patients. On the left, in color squares, it's a patient that presented with multiple PVC morphologies. And this is a very classic presentation for patient with septal substrate. You can see PVC number 1, it's a left bundle transition in B3, inferior axis, positive in 1 and more positive in AVR than AVL. This displaces this towards the left ventricular outflow tract and the septal aspect, the level of the right coronary cusp. But then you can see there's other 2 flavor of outflow tract PVC. It's a right bundle, more narrow PVC, probably closer to the conduction system, and a third PVC, which has a later transition and is way more positive in 1, probably puts this closer to the parahissine region on the right side. But if you think about these 3 PVCs all share a common area, which would be the septal aspect of the heart. And then you have a 4th PVC that is completely different in the sense that it's superior axis, but still with septal characteristics being very, very positive in one, and right bundle with no transition, so it would be in the inferior septal portion of the left ventricle. So you're now starting to think that there might be a process that allows PVCs to survive or live in the top of the heart, and then some on the inferior septal portion. In the second patient on the right side is a patient with monomorphic VT. And similarly, you see there's a classic morphology, like outflow tract morphology that was mapped to the LVOT. And then you have other flavors of more in the left, instead of the left, the right side exits of ventricular tachycardia with septal characteristics. So the clinical problem, it's going to be ventricular arrhythmias with septal ECG characteristics, and classically, you will find more than one morphology. It's a clue for septal VT. So the second step to identify septal substrate, it's the combination of imaging and EP study. From the basics again, we start with simple echocardiogram. And if you're in the EP lab, intracardiac echo becomes very useful, in which you can see sometimes this hyperechoic, believed to be non-specific, but correlates very good in our patients with septal VTs, in which you can see some dyskinesia, sometimes you can see thinning, and then more hyperechoic regions. This is the basic, image that you will get in anywhere. CT scan reconstructions in which you see classic septal substrate extending from the anterior portion down towards the inferior. And you can start thinking how that EKG morphologies I show you can perfectly fit in this area, some more towards the right coronary cos and the top of the septum. That's why they're outflow tract. And then if you move down the parahysm region and you move further down, you're all the way at the base of the left ventricle. So this classic intramural substrate can explain those characteristics of ECG. Cardiac MRI, also very helpful, and you start to see how there is an endocardial portion that could be layered as more healthy tissue, and then intramural delayed enhancement. A classic image of cardiac sarcoid, predominantly intraseptal in this patient, very, very diffuse, but you can see the inflammation in cases of intramural arrhythmias. In the EP lab, characteristically, we have described the frequently normal endocardium, and you can see here the correlation in voltage map with the MRI. Yes, the endocardium is normal because we're touching a layer of normal tissue, but classically, you will see a very abnormal unipolar voltage map representing next layer of tissue that it's abnormal in this case because it's the septum. It would be the intramural region. Physiologically, because there is affection of the septum and the conduction system goes through the septum, we have also described that if you pace in the right ventricle and you measure the transeptal conduction time, you're going to have a disrupted pattern in which there is a delay activation at the base of the left ventricle when you pace in the right ventricle, usually coming through the apex, and it's earlier at the apex than at the base. And these are all clues that you can combine either all in the same patient. Sometimes you have one or another that indirectly suggests the presence of intramural septal substrate. Now, I bring this up because in electrophysiology, the real EP characteristics of substrate is the recording of electrograms with delay activation, so-called lay potentials, lavas, etc., in which you have the far field signal when you touch the tissue with contact mapping, and then you have delay activation in that tissue you're touching. If you start thinking about this, the real definition of intraseptal substrate would be if we could record signals inside of the septum and demonstrate that all this imaging that suggests the presence of abnormal conduction in the septum, it's in reality what it is happening electrophysiologically. So how can we do that? So that take us to an important step forward, I believe, in the mapping of ventricular tachycardia, which is the potential for recording late potentials inside of an accessible intramural space. So we have been doing this now for a few years, and what we are doing is trying to use the arteries and the veins for either VT or PVCs to use them as highways in which we can place different type of recording catheters or wires inside of the muscle so we can record the activity inside of that area. We perform a good venogram, and that tell us the location of these branches. You can see here the septal perforators that drain into the AIV, so the so-called septal veins that go down into the septum in the RAO and LAO. By doing that, we have been able to place catheters, and this image is a correlation of a patient that has a very abnormal delay enhancement in the septum, in which we have placed, through cannulation of the first septal perforator, a multipolar, octapolar small catheter in the septum. We can identify in the lab on intracardiac echo, not only with fluoroscopy, but with eyes, the location of that catheter. And you can clearly see here, this catheter is located in the septum. That would be the area of the delay enhancement. And what we've been able to do is to clearly document that direct recording of fibrosis, delay conduction, slow conduction, by defining the characteristics of the tissue. And you can see clearly here in a patient with a long PR, have presence of septal substrate on the MRI, the lay potentials inside of that muscle. We describe this with unipolar recordings, and we compare it to normals in a publication in 2019, and we consistently showed in a number of patients that the unipolar characteristics of the septal substrate, it's one of classically electrophysiology findings. These are the controls in which were normal, and we demonstrated the amplitude was lower, the duration of the EGM was longer, and 100% of the patients that had septal substrate had a fractionated multi-component EGM. So now that we were able to, using different modalities, define septal intramural substrate, then how can we use it to map arrhythmias? In general, all the EP techniques for mapping could be potentially used in these cases. So I have examples here that prove the utility of a unipolar wire for mapping sustained ventricular tachycardia. This is a patient with septal substrate and inferiorly directed VT that most people would think that this is exiting, and probably is in the RV side of the outflow tract, but we couldn't find any early activation in the endocardium. You can clearly see here the presence of mid-diastolic activity inside of the septum. And when we entrain in this VT, you can see that we have concealed fusion and a perfect PPI for the VT. So it is possible to define better circuits and activation. This is an example of a patient with premature ventricular contractions in the setting of septal substrate, and you can see the lay potentials in the area, and activation mapping clearly shows the presence of early activation inside of the septum that goes towards the epicardium and then towards the endocardium. And again, the location of that catheter inside of the septum based on intracardiac echo. This is a right ventricular flow tract, the left ventricular, and the catheter right on the center of the muscle. So how can we define targets? And especially if you don't have any good information after mapping the endo and the epi. So where to ablate? That's the question. And we have been using this technique to essentially find the earliest site of activation In this case, we find the earliest site of activation in that intramural space. You can clearly see here the early activation in 1-2 in that octapolar catheter going from intramural to epi. Now, we couldn't find any early activation in the endocardium. So where do you ablate? Well, if you know that your early activation is intramurally, then just based on fluoroscopy and 3D mapping, you can place your ablation catheter opposite to the area where that other catheter is. In this case, the ablation catheter in a retrograde fashion opposite to Epistar 1-2, and you can see the endocardial signals are late because the endo is protecting for a layer of tissue from the intramural space. However, ablation on this side is successful in eliminating the PVC. It usually takes a few seconds because you need to penetrate into the tissue, but it usually is successful, even though you would never suspect that you were late based on the endocardial activation. So we have designed an approach to try to guide ablation of intramural substrates by using venous mapping. The first question always is there evidence of intramural substrate based on the techniques that we describe? And then there's going to be 3 activation patterns once you do endo and intramural and venous mapping. So you basically have epi by putting a catheter in the AIV, you have intramural and you have endo. The activation mapping from epi early to endo, that means that you're very early in the epicardium and you have a true subepicardial space. In these cases, you are looking at an epicardial ablation, an epicardial mapping, and depending on the distance, you could try to target from the endocardium, but usually means your site of origin is subepicardial. Then there are the patterns that we are talking about today, which is intramural location. That means that it's early in the intramural space, so your venous mapping is going to be earlier than anything else. And as I described, endoablation opposite to early sites to target that tissue. And then, of course, you have the pattern of being early in the endo. That means you have an endocardial to epicardial activation, and that's something you ablate from the endocardium. So you can combine these activation patterns for earliest site of activation. And of course, if you have sustained arrhythmias, you can also do pace mapping and you can do entrainment. Endpoints for ablation could be useful because you can ablate until you don't capture. This is a patient with VT in which we have proof and entrainment, and basically we're guiding the ablation, okay, to the earliest site. You can see, just like I described before, the earliest site was the wire. We couldn't find anything good in the endocardium, and we ablated on the wire opposite to the wire from the endocardium with RF. And you can see it takes time to penetrate, but the VT slows and terminates. And then when we continue ablating that septal substrate, we kept stimulating from the wire until we lost capture. So you're trying to do deep enough lesions to penetrate, and this is the problem with septal ablation. It's trying to get transmural lesions that penetrate into the tissue. This is an example with multiple catheters trying to find the best area, define it epicardial substrate as normal. But really, if you focus on this in the so-called LV annular vein, which is this vein right here that goes to the septum, you can see these fractionated signals, classic of intramural substrate. And essentially, our target was to eliminate the VT, but then we tried to eliminate the late potentials. And you can see here, a patient had late potentials that go away as we ablate from the endocardium. So you could use this potentially also as an endpoint, just like any other ablation to eliminate late potentials. So intramural substrate, mid-septal it's probably the most common, not only mid-septal, it's intramural. You can have intramural on the lateral aspect or other areas. You have to try to identify, base it with ECGs. This is your first clue. Then you can have anatomical tools like imaging, unipolar mapping. You can have functional tools, the transseptal conduction, and you pace the RV while mapping the LV septum. And it's useful also to know, as I described for loss of capture, to know if you're getting enough depth on the lesions from the left side, because you need to, of course, prolong conduction. The problem is that if you go for that, sometimes it will result in complete heart block. Intraseptal mapping is feasible, and it's a great tool, but it's limited by anatomy. So you either have veins or you don't. You could try to use the arteries, but of course the veins are more permissive. Try to save the conduction system as possible. However, if you really want long-term VT survival, you probably have to do extensive ablation. And when ablation fails, and we were here in the meeting today, there's going to be alcohol, arterial embolization, simultaneous unipolar, bipolar ablation, and all these are potential tools for patients that fail. I want to make an important point on the utility of intramural recordance, because it's direct recordance of slow conduction. You now have the ability to really define substrate electrophysiologically in the mid-septum. If you use endocardial and epicardial ablation, it's very useful to define where to ablate. In the setting of septal substrate, really you don't have access to epicardial for the substrate, so you're talking about really endo and intramural recordings from RV and LV, and then the wires or the catheters in the venous septal perforators. It's particularly very useful when you don't know where to ablate, because there's nothing good on the endo. The arrhythmia elimination or modification of the substrate could also be used as an endpoint. And a provocative thought would be, if you don't have anything to define substrate, if you find lay potentials in the septum, could this be a definition of potential marker for sudden death? And this could be part of the future. But we really got to a point that for the first time, we can define intramural substrate based on electrophysiologic characteristics of its slow conduction. I thank you very much to the organizers. I am very happy to be part of this fabulous meeting, and I wish a very successful Prague Rhythm 2022 to everyone. Thank you.
Hello, my name is Professor Dhanjal, and I'm going to spend the next 15 minutes talking about the role of decrementing evoked potential mapping in ventricular tachycardia. So here are my disclosures. And we're going to look at what effectively decrementing evoked potential mapping is, an example case, followed by how to identify deep areas on your maps, and does deep mapping impact on clinical outcomes? So we know that from animal and human studies that the isthmus, we have always believed, is the zone of slowest conduction. However, this is actually a misconception, because translational work has shown that the VT isthmus conducts at relatively normal velocities, around 0.6 meters per second. The slowest areas of conduction in a re-entrant VT circuit are in fact the turnaround points, and these are the entrance and exit sites of the VT. And it's these areas that we try to map and identify using our mapping methodologies. And it's over the years that we've actually realized that late potential mapping alone may not successfully identify this. And a lot of work has been done on this subject by other colleagues, including Della and Roderick's lab. And in fact, there was the advent of isochronal late activation mapping. We're going to look at how deep mapping helps to identify these turnaround points and to identify functional VT isthmus. So one of the best papers that I've seen on this subject was published back in 2015. And this is an example of why we want to identify decrementing potentials. So the important philosophy here is that VT is a re-entrant circuit. And for a re-entry circuit to occur, we need unidirectional block in one of those limbs. And prior to unidirectional block, we see that potentials that identify unidirectional block decrement before they develop unidirectional block. And it's by identifying these decremental sites that we can predict that these are the sites within the scar that may then result in unidirectional block and reentrant VT. Here on the electrograms, you can see a paced beat S1, another left ventricular paced beat S1, and then there is an S2, S3, and S4 at shorter coupling intervals. And in the first paced beat, you see the far field QR electrograms, bipolar electrogram, and then you see the near field late potentials. And here you see an arrow, a chevron from A to I and then I to K. If we go over to this substrate map, this is a voltage substrate map of this left ventricular apex. And you can see the red areas of dense scar, blue areas of healthy myocardium. And A to I is entrance into the channel through this limb, and K to I is entrance into the channel through this limb. So that's why we see this chevron activation, the wavefront coming down and entering the star channel A to I and K to I, with I and H the latest area of activation. However, when we put our S2, S3, and S4, these shorter coupling intervals in, we are stressing the conduction within this channel. We are stressing the K to I limb, and we are stressing the A to I limb. And if we look at the stressing of the K to I limb, you see that if we focus on EGMs in pole I, the bipole signals in pole I, we can see we have our far field and near field, far field and near field, S2, far field and near field decrement, and then we see an S4, far field, and we have block. And it's this block that then precedes VT induction, and now we have reversal of activation of K to I, with instead of K activating prior to I, we now see I activating prior to K. So we've got channel reversal of conduction with K to I. We've seen decrement, unidirectional block, and then reversal of activation as we see reentrant VT. And if we look at the actual bipolar EGMs, we can identify that reversal in activation by looking at the bipole signal. And here you see that late component with a positive then negative deflection. And then as we then induce VT with activation direction reversal of this signal, we then see a negative, then positive. So positive, negative, and that near field late potential that is decremented in VT reverses channel wavefront propagation, which reverses from positive, negative to negative, positive. And so in terms of VT mapping here at the University Hospital, Coventry and Warwickshire, we combine conventional and contemporary mapping approaches. We combine entrainment, activation and pace mapping with substrate, lava and late potentials. And then the latest thing that's in the field of VT mapping is conduction channel identification. And how do we do that? Different groups do it in different ways. Voltage scanning, imaging using ADAS-like software, and decrementing of both potentials all help to identify functionally active conduction channels. And our workflow is to identify a substrate map, followed by late potential deep mapping. We then try to induce VT in every case. And if we have a stable VT, we'll perform an activation map, an entrainment map if the VT is stable, pace mapping if the VT is unstable. However, with strategic activation mapping, stamp mapping, if your VT is unstable and you have your mapping catheter placed where you think the isthmus is, even a few beats of VT and an unstable VT can give you really nice electrogram data of mid-diastolic potentials. We ablate the conduction channels as identified with deep mapping and the VT site of origin as identified with pace mapping and activation mapping. Prior to final VT stim, we perform a substrate map and remap to make sure that we've eliminated the substrate. Like in most labs throughout the world, complete success is elimination of all clinical and non-clinical VTs, partial success is elimination of clinical VT only, and failure is the VT, clinical VT is still inducible. So we use predominantly the HD grid multipolar mapping catheter to map our deep potentials. And the beauty of this catheter is that it has helped us to overcome bipolar blindness. Here you see wavefront activation from top to bottom and the linear spline to pick up this. If the wavefront direction alters, The linear splines see nothing, but the orthogonal vector poles then pick up the bipolar EGM and the wavefront activation. We did some work to see whether the wave for solutions to help overcome bipolar blindness made any difference to substrate maps. And actually, this data shows that the area of dense scar was smaller and the border zone area was greater. And it's this border zone area which is the area of interest for VT ablators. It's this area where we tend to find our interesting signals. We looked at the additional channels identified with the wave configuration, and we showed a 30% increase in the number of conduction channels, and 93% of the signals identified these additional channels were the orthogonal vector EGMs. So one of the first studies that looked at deep mapping was the Porter-Sanchez group, and here the electrograms, you can see a sinus beat with late potentials, and with extras, you can see the drivetrain with an S2 extra. You can see this late potential from the far field signal to the near field signal was 23 milliseconds, 123 milliseconds. And with the S2 extra shorter coupling interval, that near field to the far field to near field duration has prolonged to 155 milliseconds. And anything that prolongs more than 10 milliseconds is defined as a decrementing potential. In this study, 20 patients were recruited and 16 patients underwent multipolar mapping and 4 patients point-by-point RF mapping. And you can see the point density, wasn't huge, and up to 890 points for these maps. If we look at how the decrementing mapping was performed, you can see here there is a drivetrain with an S2 at the end. And you can see that these late potentials in EGM1 and EGM2 do not decrement, whereas the EGM3 decrements. And it's this difference in Y1 minus Y2, which is what we want to see on our maps. But unfortunately, there is no mapping system that can automatically differentiate between this difference in duration of the EGMs from an S1 and an S2 map. Here you see the example, the 1 to 3 milliseconds, the late potential has gone out to 155 milliseconds with that S2 extra. In the Porter-Sanchez study, these S2s were put in after a drivetrain. So there was a drivetrain at 600 milliseconds, followed by a single extra that was at VERP plus 20. And VRP plus 20 was chosen to stress the myocardium to its maximum. And that was the interval that was used. And you can imagine that having to do a drivetrain and an S2 at all the areas within the scar zone can take quite a bit of time. The clinical findings in this study was that the late potential median area was 16%, the deep potential median area was 4%. So what this shows you is that a late potential map gives you a lot of area to ablate, whereas a deep potential map really hones in to the area of interest. The overall ablation time was 30 minutes, and you can see that the sensitivity for both the late potential map and the deep potential maps were good, but the specificity for the deep potential map was better. You can see that rather than the late potential map, which picks up a larger area, the deep map, because it homes in and it's more specific to the isthmus regions. Of the 20 patients, 75%, 15 were VT-free at 6 months. A second study was published by the Bart's group, led by Professor Pierre Lambiase. And what this study did was, rather than doing a drivetrain and a single extra to identify the functionally active late potentials, they put a single extra in, and the single extra, the sensed extra, was put in at VRP plus 20, again to stress the myocardium to its maximum. And you can see here on the bottom left, the sinus rhythm late potential map showing this small area. And with the sense pacing protocol, you see a much larger area that has been defined. And in the electrograms, you can see that there are fractionated components within the QRS, and with the sensed extra, these fractionated components decrement out. Now, the clinical findings of this study were slightly different in that the late potential area in sinus rhythm was smaller, and the deep potential map gave you a much larger area. One thing to point out is that the deep potential map in this study was performed by doing a turbo map of the sensed extra beat. So not truly looking at a difference in timing between the sinus beat late potential and the sensed extra beat late potential. The sensed pacing area was approximately 19.3. It's been reported as millimeters squared in the study, but I believe this should be centimeters squared, versus 6.4. I believe this should be centimeters squared during sinus rhythm mapping. So in this study, the deep area was large, the late potential area was small. And if we look at the bar graph here, the amount of VT burden to the right was significantly greater than the amount of VT burden to the left at 12-month follow-up. And 90% of patients were free from ATP and shocks. Now here at the University Hospital, our protocol is a combination of portasanjas and parts. Rather than doing a drivetrain of 6 to 8 beats followed by an S2, we put a drivetrain of 2 plus the sensed extra to shorten the duration to identify the area. It also allows the activation wavefront in looking at the late potentials to come from the same area. With the sense pacing protocol from Bart's, there is change of two things, both the coupling interval and the wavefront direction of activating those functionally active channels. And here you can see a sinus beat with no exciting components within the near-field EGMs. However, with our sensed extras, you can see on D1, D2, there is clear decrement of a late potential. Example case, this was a 62-year-old male post-MIVT, ICD-DR with 3 ATP episodes and 1 shock despite amiodarone, EF of 25% with a prior LAD territory infarct. And we applied our VT workflow, and 90% of our cases are done under conscious sedation. Here you see the voltage map, anterior scar with a potential channel from septal to lateral, and the green tags are where we have manually annotated those decrementing potentials. The arrows show activation from the top left into the isthmus, also exit to the bottom left, exit to the bottom right, and exit to the top right. So in my mind, we have a channel here with these multiple components. So a late potential map, the green line we put at the end of the QRS, and anything that's more than 10 milliseconds, 20 milliseconds post-QRS, we label as a late potential, and the late potential map clearly identifies one of these components. We can play this map using the new arrow system with Nside X, and this is the propagation map identifying this late area. So we then do our deep mapping at the same time, and here's a sinus beat with no significant late components. We put our sensed extras in, and you can see late components on D1, D2, and late components on C1, C2 that decrement out. Here in another example, you see late components in sinus rhythm, and with our sensed extras, you see a huge late component decrement out. One could mistake this for an atrial signal, but there's no atrial signal there on the CS signals. This is the atrial signal. So this is a really large late potential that's decremented out. And when we map these, you can turbo map the late potential components. Again, remember, this is not a true deep map because it's a late potential component. So it doesn't identify those components that have actually decremented. It's just looking at the latest component. But in this case, it seems to identify 3 components of this VT isthmus. So we induce VT with stamp mapping, and this is the clinical VT induced entrance here through the isthmus and exit top left and bottom left. You can play this as a black and white that I quite like, entrance and exit. And the green dots are our deep signals, and you can see the deep signals do identify the channel and also an exit of one of these limbs. And this is the old propagation map way of looking at the same VT. So this is strategic activation mapping. So we placed the grid at the site where we thought VT would be induced. And as we induce VT, we immediately see mid-diastolic potentials. This is entrainment from what we believed was a bystander entraining here. And you can see that we have a perfect QRS, entrainment with concealed fusion. with a long stim to QRS with a long PPI. So this is all consistent with bystander entrainment. This is entrainment from the black star, and we see a perfect QRS, entrainment with concealed infusion or exact entrainment with a good PPI. So we've got the ablation catheter at the isthmus site over these deep signals as well. We see VT at the bottom, and after a few seconds of ablation with our first burn, sinus is restored. Now we've looked at the wave speed map, and we know that the slowest areas are the entrance and the exit, which our wave speed map has shown. And this is similar data to looking at speed of conduction using bunching of isochrones. Because we understand the map, we see a second VT induced with a more apical origin. So we immediately move the ablation catheter to the deep potentials at the apex and ablate, and we rapidly see VT termination. So we map post-ablation as substrate has been eliminated. We do VT induction at the end, and after a 2.5-hour case under conscious sedation, VERP with nil inducible. So this was a good outcome. So how do I identify deep potentials on the map? So this is our 600, 600, 320 interval, and we don't routinely do VRP plus 20. We're currently doing a study to look to see what is the right coupling interval to use. Is it VRP plus 20? Is it the VT cycle length? Is it an arbitrary 400 milliseconds? So we're doing multiple coupling intervals in every single VT patient to identify what correlates best with VT exit sites. This is an example of where we've mapped the septum, and this ischemic cardiomyopathy patient has got scar on the septum, green tags on the septum. VT was induced with mid-diastolic potentials on the septum. But when we turbo map the last deflection of these decrementing, what we believe are decrementing potentials, it's the basolateral LV that's been identified as late. Because what this system is doing is purely looking at a late potential on that pace beat. And you can have late potentials that are late but have not decremented, and they will show on this map, they will show with this methodology. What we've done, offline analysis, has been able to take the S1 and S2 map and do a subtraction map of the late potentials. So this truly does identify the decrementing potentials. And here we now see that the basolateral LV is not exciting, and the decrementing potentials are on this septal area. So does deep mapping affect the clinical outcome? This was the IMPACT VT study that we published last year. This was a study comparing HD grid to pentarator, linear duodeca to point-by-point RF with over a year's follow-up using our workflow. Most patients with ischemic cardiomyopathy, all patients had multiple ATP or shocks with a mean EF of about 32%. We can see we did substrate maps in all patients, activation maps in most patients. The number of VTs mapped and ablated was around 1 to 2 VTs per case. Elimination of all clinical and non-clinical VTs in the HD grid map cases was about 79%. And long-term follow-up shows that if you mapped using multipolar mapping catheters, your patients who were free of shock was almost 100%, if not 100% with 1 year follow-up, with stepwise improvement with duodeca and pentarate, with least success with point-by-point RF mapping. Just some interesting deep potentials. Here we see a pace beat with late potentials, and with our extra beats, we see the second component decrements and then blocks, with the first component still there. So at the same site, you have two different channels behaving differently. Here we have channel reversal of activation with our extra beat. So here, activation of this channel was from distal to proximal, and with our extra beat, we had channel reversal, functionally active behavior from proximal to distal. Here we see late potentials with straight sinus rhythm. And you can see here that you might think you've got one channel here, but I suspect we have two, because the D spine signals are conducting 2 to 1, whereas the A to C spine signals are conducting 1 to 1. So we may have two channels at the same site with differential functionally active behavior. And all this is geared up to what we are going to ablate. And ultimately, we don't want to carpet bomb. We want to specifically target, as in E, the functionally active channels. So in conclusion, deep mapping identifies sites of potential unidirectional block Several studies have demonstrated efficacy in the VT site of origin and long-term clinical outcomes. Further studies in activation direction and coupling intervals are on the way, and we are working on map automation. I'd like to acknowledge my research team and clinical team, and most of the cases end up with happy smiles. I just want to point out Callum Bentham, who is my tending Norgay for VT cases, who will be joining us for the live VT case. Thank you very much.
So we have some time for discussion now after all these 4 cases. I don't know if anybody is connected for discussion from the speakers, because they are already in both hospitals.
It means that